Well, good evening, everyone. I'm Halloran Hilton Hill from News Talk 98.7, and I will be serving as your moderator for this evening's East Tennessee Health Forum on Ebola. I want to thank everyone for coming out tonight and for attending. It is our intent to provide accurate and timely information to keep our community informed about what health organizations throughout our region are doing to prepare for any possible incident related to the Ebola virus. So let me say that this is an unprecedented forum that has brought together the region's hospital systems and healthcare organizations, which will share a common goal, the well-being of East Tennessee. However, while this forum may be unique, the intent of these individuals and their respective organizations is not. This embodies the cooperative spirit of East Tennessee. Our healthcare leaders and workers come together to get things done for the benefit of everyone. And this is one of the many examples of putting what's best for the community first. So, I would like to extend gratitude to the Knoxville Convention Center for providing the auditorium free of charge, and to M&M Productions USA for providing equipment for our Spanish and American Sign Language translators. We'd also like to thank our media sponsor, the News Sentinel, as well as WBIR Channel 10 and WATE Channel 6 for simulcasting this event. And we'd also like to thank News Talk 98.7 FM for replaying the forum this evening for its listeners, and to WVLT Channel 8 for its coverage. Would you join me in thanking everyone that's helped put this together this evening? Please be sure to include the hashtag ET Health Forum on any Twitter, Facebook, and Instagram post so that others can follow our discussion on social media. We have assembled an expert panel to discuss Ebola, address questions and allay concerns, and I'd like to open the forum by introducing each of the members. The first table of experts represents the Knox County Health Department and medical experts from our region's leading hospital systems and healthcare organizations. Let me introduce them. Dr. John Adams, infectious disease specialist with the Knoxville Infectious Disease Consultants. Dr. Jason Baggy, emergency department medical director for Blount Memorial Hospital. Dr. Roger Brooksbank, president of the Mid-Atlantic Group for Teen Health. Dr. Martha Buchanan, director of the Knox County Health Department. Dr. Joe Childs, chief medical officer at East Tennessee Children's Hospital. Dr. Jeff Douglas, infectious disease specialist with Tenova Healthcare. Dr. Edward McBride, vice president of clinical services for Summit Medical Group. Janice McNeely, the chief nursing officer for Covenant Health. Dr. Mark Raznick, infectious disease specialist at the University of Tennessee Medical Center. Our second table of panelists features experts from additional health and medical organizations throughout our region. Stephen Hamby, EMS Regional Consultant, East Tennessee Office of EMS. Dr. Patrick O'Brien, President of the Knoxville Academy of Medicine. Dr. Marcy Souza, Doctor of Veterinary Medicine and Masters of Public Health, University of Tennessee College of Veterinary Medicine. From the Tennessee Health Department, East Tennessee region, we have Regional Directors Janet Ridley and Dr. Tara Sturdivant. Jack Cochran, the Emergency Preparedness Director, and Gail Harmon, the Public Information Officer, and then Dr. Tom Watkins, Medical Director for the Medic Regional Blood Center. We'd like to thank each of you for volunteering your time and expertise for this event. Let's thank our panel for being here. Ebola is definitely a major topic, as you know, in the news. Healthcare professionals and personnel in the general public are all talking about this, and at this time I'd like to invite Dr. Martha Buchanan to say a few words to set the stage for the evening. Yes, please.
Thank you, Halloran. And thank all of you for being here. I'm Dr. Martha Buchanan, the Director and Health Officer for the Knox County Health Department. And what you see up here is not unusual, as Halloran said, for Knox County and Knoxville. In my short time at the Health Department, I've had many occasions where our hospital systems have come together, put down their competitiveness, and said, we're going to do what's best for our community. And this is one of those times. And so I'm grateful to get to work with professionals like that who care so much about the community and want to provide information to you about what's going on. And so our job in public health is really about educating and responding, and have a whole department dedicated to emergency preparedness. We take calls about reportable diseases all the time. So our role in Ebola is not about treatment like it is for these folks. Our role is about identifying and protecting and getting people the help that they need. So that's what we would be doing in the event there was an Ebola patient here in Knox County. We've already fielded many, many questions daily about concerns and fears that people have, and we're happy to do that, and we'll continue to do so. So what's going on with Ebola? As you know, there's an outbreak in Africa. 3 main countries involved are Liberia, Sierra Leone, and Guinea. Those are the 3 countries where they have the largest number of cases, and there's a smaller outbreak in another country of unrelated, actually, which is kind of confusing, but an unrelated Ebola outbreak. But Africa is new, Ebola is not new for Africa. Ebola has been causing outbreaks in Africa since the 1970s. Most of them have been much smaller than the one we're seeing today, but the death rates have been similar, anywhere from 50 to 80% in that country. And so you might ask yourself, how does that happen? Well, you got to think about the difference between Africa and the United States. In the United States, we're used to things like flushing toilets and running water and sewage treatment plants. They don't have those everywhere in Africa. So is it more of a challenge to prevent disease overall, especially something like Ebola? And the other difference in this outbreak, and why it's one of the reasons we think it's so large, is it's occurring in a part of Africa that hasn't seen the disease. And so what happens when a community sees an illness, some people survive the illness and they have immunity. And they protect other people around them, and they don't get sick the next time it comes around. So you don't see as many cases. In this case, nobody had immunity. Nobody had any protection. And so many more people are becoming ill. And so that's part of why it's so different. So that's Ebola in Africa. And you all are aware that there was a gentleman who was a Liberian national. He traveled to Dallas and became ill after he got to the United States. He has subsequently, unfortunately, passed away. From him, 2 nurses that cared for him in that hospital have also become ill, and they're currently being cared for in other facilities. Facilities that's important to know have cared for 5 other cases of Ebola, and workers who got sick while caring for somebody in West Africa came home to be treated, and there have been no secondary cases. So none of the healthcare workers that have cared for those 5 folks have gotten sick. So it can be done. It's being done. It's not new. And also, the other thing you need to know is 3 of those people have recovered and gone home. So that's great. We know that can happen, and we can see that continue to happen. The other piece that a lot of people aren't registering is that Nigeria had a case of Ebola, and a few other people got sick. I don't remember the exact number. But what's happened is they've gone 42 days with no new cases. That's 2 incubation periods is what we call it, how long it takes the virus to make you sick. So we've gone 2 incubation periods with no new cases. The World Health Organization declared them Ebola-free. And also in Senegal, there was a case, a single case. No secondary cases occurred. So we know it can happen. We know with careful planning and careful attention to detail, people can safely be cared for and cured of Ebola. So we know that can happen. So what is Ebola? What exactly causes you to be sick? Ebola is a virus, and you get it from direct contact, from blood, body fluids like diarrhea, stool, vomit, and like I said, blood. It affects the organs. It affects the GI tract, your stomach and your intestines, and gives you diarrhea and vomiting. It doesn't so much affect your lungs like flu does, so you don't really cough a lot of it out. So it's not one of those things you cough out, and it's not airborne like chicken pox and measles are. So just being in the room with someone who has Ebola is not going to put you at risk of having Ebola. You have to have that direct contact that you're not going to get just being in a room with someone. Going to a city where they had a case of Ebola doesn't put you at risk for getting Ebola. Flying on a plane, going into that airport doesn't put you at risk for getting Ebola. So travel in the United States is very safe. Travel in general is very safe. We're doing screening and some other things. We're stepping all those efforts up. And so Our goal tonight is really to provide factual information and to give you the information you need to feel comfortable and secure and safe. Not that we got this, but that we're working together to protect you and protect our community and do the best we can to keep people from getting sick. So that's really what we're about tonight. We want to answer your questions. We want to answer your questions honestly and transparently. And I know these folks will do that. These guys know a lot more about treating Ebola than I do. So I'm glad that they're here. So that's what we're about tonight. Let's get to answering your questions and hopefully alleviating some of the concern that might be out there. Thank you.
Thank you, Dr. Buchanan. All right, let's get to work. Several of these questions that I have were submitted in advance by community members to our questions at ethealthforum.com email address. The discussion will also feature questions that our panelists have heard from the community and were identified as important areas to cover. One more important note, as you came in, the greeters provided a paper and pen for you to submit written questions. Before submitting your question, please review the guidelines on the back of your program. Written questions may be submitted for consideration up until about 6:20, when they will be collected from the audience. The questions will then be reviewed to ensure a variety of topics to avoid duplication. The panel will address many of these questions as possible during the Q&A session, which will start at 6:30. At 6:30, we will invite those whose questions were selected by calling your name to come to the microphone and ask the panel your questions. So let's get started. And we have several questions. And we've covered some of this, but just as a matter of clarity, I want to start with Dr. Mark Rasnick. Is there a cure or vaccine for Ebola?
So the simple answer to both of those questions right now is no. There are investigational products, drugs that appear to stop the Ebola virus from invading cells or replicating. There's a product that's been shown to be effective in animal studies. It's the famous ZMapp that many people have probably heard about in the reporting, but nothing that has been through a human trial to demonstrate effectiveness. And these drugs appear to have been used on some of the Ebola patients so far, but you can't use experience from a handful of patients to make a conclusive statement about whether something works. It's hopeful. One of the drugs that's being used is an experimental antiviral it's currently being studied to treat other viruses that are more common than Ebola, much less life-threatening. There have been no human or animal studies on that drug for Ebola, but in the test tube in the lab, it appears to have effectiveness. There's also the transfusion therapy many of you have heard about, where you give immune serum from someone that's recovered from Ebola to try to protect a patient. We have no studies that say whether that works or not. What we do have is a legacy of experience with other infections that using that kind of approach, giving the immune serum from someone that has recovered to a patient suffering from early stages of the disease, you might actually help them recover. And so that's the drug therapy piece. The vaccine piece is all investigational. Keep in mind that every previous Ebola outbreak has only involved a few hundred patients and died out within a few months. And the places where Ebola has occurred have been very austere environments, and there really hasn't been an opportunity to field test a vaccine up until now. It's just you have to have a place where you can actually run a vaccine trial, and places where Ebola have occurred, not really the best environment to try to do a clinical study. These studies are now being ramped up. There are many people working on different candidate vaccines. That's something that we'll probably need to get this outbreak under control in Africa, but it's something that probably won't be available for months in any type of effective doses, and so more to come on that. But even without antivirals and vaccines, there are things we can do for a patient with a hemorrhagic fever. There's a disease called dengue that has a hemorrhagic fever manifestation. It's not nearly as lethal as Ebola, and it's not contagious to other people, so it's much easier to treat. There's not the worry of danger to staff. But there's things you can do with supportive intensive care unit care, transfusions of blood or other clotting proteins, and just good medical care that we can bring to bear for a patient in the United States that would not be available to someone in a more austere environment. And so we can treat the patient, we can provide good supportive care, try to reach out for other things as available, but basic good medicine should help these patients recover.
So let me ask a follow-up question then. The question here is, if you get Ebola, are you going to die? I know the death rate is about 70%, and then why is it spreading so fast in Africa, not here?
So are you going to die? The answer is it's not certain. It is certainly a fairly high risk of that, 70% in Africa. But that doesn't necessarily mean in an otherwise healthy, well-nourished population, that mortality rate will still be 70%. If you take measles as an example, in Africa, in a malnourished population, measles kills about 28% of the people that fall ill with it. In the United States, with a well-nourished population, the mortality rate is much less than 1%. And so, you know, we can't say that Ebola is going to be no big deal here, but we just don't know how it's going to behave in an otherwise well-nourished population. As far as why does it spread in Africa, I've had the opportunity during a previous career in the military to provide medical care in Africa in a variety of settings. And it's an incredibly limited setting. Many of you in the audience may have been on mission trips, either to Latin America or Asia or Africa. And some of the places I've worked in, basic things like gloves and masks and gowns that we take for granted aren't available. Nursing care is largely provided by family members, things like basic cleaning of the patient, bringing meals, tending to the body after death. There's not a professional cadre, shall we say, of folks that step in and do that. And so in that kind of environment, you really facilitate a disease that's spread by body fluids, being spread rapidly through families and close social networks that have contact with that patient, and especially the body after death.
Thank you for your answer. Next question is for Dr. John Adams. How do you get Ebola? Can it be spread through coughing or touching? Can it become airborne? How long does it live on surfaces like money or doorknobs?
Well, we've already briefly mentioned how one can get Ebola. It requires contact with body fluids like blood, stool, diarrhea, anything that might contain blood if somebody is bleeding. But just about any body fluid in somebody who is actively infected with the virus can contain it. And if it gets onto broken skin or a mucous membrane like your eye or inside your mouth, then the virus can gain entry into the body and begin to multiply and set up an infection. But it requires that kind of contact to actually get sick. As Dr. Buchanan mentioned, just being in the same airspace with somebody who has Ebola, breathing the same air, puts you at no risk. The disease is not transmitted through the air. Now, if somebody were to vigorously cough, we've all probably seen those high-resolution pictures of a cough that shows this enormous cloud around. Well, those little tiny droplets, which will only travel a couple feet, could contain virus particles. And if you were to breathe them in or get them into your eyes or into a cut, then yes, it could transmit that way, but that's not an airborne route. Airborne means something that can actually float in the air for a long ways, like chickenpox, measles, tuberculosis, diseases that we deal with regularly. And Ebola is just not one of those. It's got to be on a particle that will fall out of the air very quickly from its source, or be on something fluid that you touch and then get into you that way.
Money and doorknobs.
Money and doorknobs.
Other tactile surfaces, yeah.
Yeah, you know, doorknobs and toilet seats and all that. Ebola can survive for several hours on a surface. A lot depends on what is surrounding the virus when it's there. If it is deposited in a fairly dilute situation with very little fluid, particularly very little protein or other materials that are part of the normal body fluids, it won't survive very long, a few hours perhaps at most. If it is in blood on a surface that's slowly drying, it can survive for days potentially. But in most of the situations where somebody might be contaminating a surface, it's probably going to be in a healthcare setting where we're using disinfectants that are extremely effective. And if it were to be in a home setting, very common household disinfectants will also very readily kill the virus. It's not hard to kill if it's on a surface, just a very dilute solution of bleach, common ordinary bleach, 1 part of bleach to 9 parts water. It sounds kind of dilute, but that's extremely potent against a wide variety of organisms, Ebola included. Alcohol will also do that. So it's very easy to disinfect, and it's just not going to survive very long on something that one person might touch and somebody else come after them without disinfection in between. And if it were to get on a piece of money, it'd have to be pretty bloody saturated. And I would imagine that most of us would probably turn down that bill, even if it's a 20 on the street, not pick it up.
So let me ask you this as a quick follow-up. What about wastewater treatment facilities? Is there risk there?
The simple answer to that is no.
Okay.
And again, going back to what Dr. Buchanan alluded to in her comments, we're very blessed in the first world to have the kind of water and waste treatment that we have. And waste treatment in the United States in particular, and probably in most of the Western world, is specifically designed to inactivate microorganisms, or at least pathogenic ones. I mean, part of that actually uses sort of the good bacteria to get rid of the bad and to get rid of viruses. But there's multiple stages and steps built into the waste treatment systems that all of our cities use, each one of which carries an extremely high probability of inactivating any kind of virus that might be present. And then when you add them sequentially, it basically becomes so infinitesimally small that it's zero. It just can't transmit that way.
Let's move over to Dr. Jeff Douglas. Thank you for your comments. Are certain people more likely to catch Ebola than others, and what are the risk factors for contracting Ebola?
Well, those we've already mentioned who come in direct contact with a patient with Ebola are those who are at risk for contracting Ebola. Seems pretty obvious. Contact means contact in general. We're speaking of contact with blood or body fluids. So those are the risk factors for contracting Ebola.
All right, so let's drill down and be a little more specific. When do symptoms start showing, and can you spread it before you're symptomatic? Does it incubate and can it spread before you actually show any symptoms? Or would you describe the symptoms just for clarity?
So the typical time period of the current outbreak is about 10 days from exposure to when people become symptomatic. The range is 2 to 21 days. People talk about the 21-day number pretty frequently, but some people have become symptomatic as early as 2 days after exposure. Most common symptoms are fever, vomiting, diarrhea, and what's called anorexia, which means loss of appetite. There's many other symptoms. Obviously, nausea is frequently part of it. They can have joint pains. They can have muscle aches. It appears initially like a typical viral type of illness. Aches and pains and fever. It can be very nonspecific early on. The GI symptoms generally come on a little later, about day 5 to 7, and then symptoms sort of rapidly progress from there. As far as spreading the disease, the very firm statement from every source that you can look at is that patients are not contagious before they have fever. There is good data on that. They've looked at outbreaks where they've cultured for virus very early in the onset of the symptoms. It's actually hard to find the virus in the blood in the first few days of the illness. If there's no virus there, they're not going to be contagious. So again, it seems very reasonable to say that if they don't have fever, they don't have symptoms, they're not contagious.
Thank you, Doctor. Now to Dr. Martha Buchanan. If someone has symptoms of Ebola here in East Tennessee, what should they do? Where should they go?
So if somebody believes they've been exposed to Ebola and they have symptoms of Ebola, we really want you to pick up the phone and give us a call if you're not that sick, if you're just feeling badly and you're afraid you have Ebola, at the health department, so we can talk to you about what's going on and what your exposures have been, and also give you guidance on where to go and what to do next. And we want to alert any hospital you might be going to that you're coming so they can be prepared. So you don't just show up on the doorstep and they're not prepared for handling that, keeping others safe and taking proper care of you. In addition to that, we want to let the EMS know if they're going to be transporting you that you might have Ebola, so that they can also be prepared to protect themselves and take care of you when they get there. So we want to be a resource at the Knox County Health Department to answer questions about Ebola if you're concerned. Certainly, if you have a private physician and you want to seek medical care there, again, pick up the phone and give them a call and get their advice on what they want you to do. Do they want you to come to the office? Do they want you to just go to the ER or something else? But informing folks before you go there is really important, because they need to be prepared to keep the other patients safe, to keep themselves safe, and to take the best care of you they can in a timely fashion. So that would be my advice if you believe you have Ebola. But you have to have an exposure to someone else who's had Ebola in order to get Ebola.
All right. Thank you for that. This question is for Dr. Roger Brooksbank. Are local hospitals prepared to handle an Ebola patient here? Is the staff trained to recognize the illness, treat the patient? Do they understand the protocols?
Great question, Howard, and thank you for the question. First of all, I'm an ER doc. I'm lucky enough to work at other hospitals, both big and small. We've gone through a lot of training and processes from all hospitals in the region to make sure that we are as good or better than anybody else in the country. We're lucky enough to have a community of close-based hospitals that work collaboratively together to do that. So I think, yes, we are ready, we are trained, we are ready to do the best we can to take care of patients. As far as recognizing, you heard the infectious disease specialists on the panel talk about this. This is like the flu. This is a virus. But like in medical school, we're taught our first key thing is to get a good history. A good history for us about travel history, exposure to someone with Ebola is going to be key for us. And yes, we've been trained on safety procedures as well.
Thank you. Next, I'd like to ask Janice McKinley, if somebody goes to a hospital with symptoms of Ebola, walk me through what actually happens next.
I'll be glad to do so. We're training our staffs right now to use 3 words: detect, protect, and respond, meaning triage, ask the appropriate questions, as you've heard the other panelists say. We want to know their travel history, and we want to know details of their symptoms. We will then ask them to put a mask on immediately. We will put them in a private room with a bathroom, and we will close the door. We will quickly call our supervisors and assess the situation more thoroughly. We'll ask our staffs immediately to put on the protective equipment that we have readily available for them. And then we will activate our internal plans, and all of our hospitals in the city have those plans. And the first call is to the health department for support. And then we will further go about caring for this patient in a supportive way of their symptoms.
All right. Let me follow up with this. This is a question we received via email. What is the hospital protocol for hospital staff who've come in contact with a suspected or diagnosed Ebola patient? And can healthcare workers protect themselves? For instance, will the nurses in these facilities have hazmat suits available for themselves that have contact with Ebola patients or suspected patients? We've had news video that's been out there where the nurses did not have the proper hazmat suits. So talk about that.
Well, as you know, this has been a very fluid process over the last 2 weeks. We are constantly evaluating our protocols, and the chief nursing officers in the city have had a phone call. We've talked almost daily to talk about our protocols. As of last evening, you know, the CDC did update the protocols to say, first and foremost, all skin should be covered. So we are looking at all of our equipment that we have, we call personal protective equipment, so that we can make sure our staff is appropriately dressed. And one of the things that they have to be able to do is put that on the right way. The CDC now is saying that we need to have a supervised observer, somebody that's trained, that knows exactly how to put the equipment on, that watches our staff do that. And also, it's very, very, very important that they understand how to take it off appropriately. And so we are beginning the process in all of our hospitals to train our staffs appropriate how to put it on, how to take it off, and how to protect themselves. For the most part, most of us are not choosing to use the hazmat suits at this particular time. We are using a different type of respirator, which has to be fit tested for the individual as well. It takes a lot of training to do this effectively, so we really want to make sure we get the right training, and then we begin the practice so that we're prepared.
All right, thank you for that. Now let's talk with Dr. Jason Baggy. Some emergency rooms are placing signage with Ebola screening criteria at the doors. Others are changing their intake and visiting processes. And each hospital may have different rules and procedures. What can someone expect when they go to the emergency room? Will those procedures change as the CDC updates its recommendation? What are you doing in terms of signage, rules, and are you changing to keep pace?
So each emergency department has its own internal physical layout, policies, procedures, but they do all follow the same general course. Yes, there's signage can be put up, and patients will see that, family will see that. The most important thing, like the others have mentioned, is the early identification. You will be asked questions about travel and other symptoms of Ebola and other infectious diseases. If at that point it's determined, and it's the initial interaction, it's determined that you're a significant risk for Ebola infection, you'll be immediately isolated, and again, the hospital procedures will then go through the steps of isolation, protection, and identification. In terms of changes in guidelines and changes in protocols, I would say yes. As the CDC, as the different agencies change their recommendations, we will too. We'll change what we do in our policies and our procedures, and that's pretty common. We do that regularly every time there's a different flu strain or a different outbreak of a gastroenteritis bug or something. We're pretty adept at changing that. So I do expect to see changes as we learn more about it, and I have no reason to doubt that will happen, and I feel very confident that we'll be able to follow us along.
Thank you for that. This next question is for Dr. Ed McBride. If somebody goes to a doctor's office or a clinic, not a hospital, and it turns out that they have Ebola, what would happen?
Well, I think first, it's been touched on that we're to appropriately assess the patient when they present as far as level of risk. For folks who have not traveled outside the United States to an area endemic with Ebola virus disease at this point in time, or exposure to someone with Ebola virus disease, the risk in East Tennessee is essentially zero. Okay, so appropriately identifying patients early in that process, and that's the first thing we're training our office workers to do. The front office staff, I've always told my folks, you're the first and last smiling face anyone will ever see coming in this office, and they're critically, a critical part of our team. Those folks ask the appropriate question. If you call an office today, you may very well be asked the question, have you traveled? Well, no, I'm just calling for follow-up of my diabetes or my COPD. Don't be offended. It's an overabundance of caution that we're taking at this point in time. Just as we should be prudent in our response, I'm telling our folks we have to remain steadfast in our commitment to serving patients in our community. And so someone walks in the door and they are at risk. Okay, first of all, they wouldn't be diagnosed in the office. The diagnosis would occur further down the chain, but say they're identified to be at risk. Much as Janice has said, we're to isolate that patient. We are to activate the appropriate chain of command. We are to notify the health department with their guidance and direction and support. Next steps would be taken to facilitate the transport of that patient to a definitive evaluation and treatment center. And those are the steps that we would take in the outpatient arena.
All right, thank you very much. This next question is interesting in its phrasing. It's for Dr. Buchanan. This question says, if and when we have the first confirmed case of Ebola, what will exactly happen next? If and when?
Thank you.
Let me take that out of
If or when?
there. If.
So if we were to have a case, an actual case of Ebola here in Knoxville or Knox County, first thing, obviously the person is going to be isolated at a healthcare facility, and hospitals will enact their regular protocol for protecting their staff and protecting other patients. And we will be talking with the patient and getting a detailed travel history. We will also be talking with the patient and getting a very detailed history of who they've been in contact with since they became ill. So that's why early identification is so key, and why we've started change some things in our outpatient arena so that we can identify people early and know before they, do a lot of things while they're just not feeling so good and putting other people at risk. So we want to know as soon as somebody's sick, we want to know that who they are, and we want to get them to a place where they won't make other people sick.
Thank you. We have a couple of questions related to that for Dr. Cho Childs. How is Ebola treated? What's the treatment plan here locally? So when they do get a patient, how is it treated?
Sure. Well, Dr. Resnick mentioned earlier that there really isn't a vaccine or medications that are really found to be for sure beneficial for Ebola. And I'm an ICU physician at Children's, but the principles for treatment are pretty much the same for children and for adults, and it's to support the patient. The patients that have survived Ebola, their immune system has figured it out. They figured out how to develop antibodies that are effective in fighting off the virus. And when we're talking about treating Ebola patients now, you really want to support them so they can win the race. Their immune system, they can survive long enough that their immune system can figure it out. So the principles are to support the bodily functions that are disrupted, and that is pretty basic. It's IV fluids, replacing electrolytes or the salts in the body and keeping those things in balance. If they need oxygen or breathing support, you provide that. If they need blood pressure support, you provide that. They're at risk for secondary infections, and those things can definitely happen. You need to monitor for that. But it's just those basic principles of supportive care, hoping they win the race. And in fact, as was cited about in our country, there is promise that can be very effective.
So let me follow up, though. So for clarity, the way someone beats Ebola is through their immune system, period. Like, we don't do anything. We try to make sure that their immune system is robust enough to do the fighting, but we don't have a pill, we don't have any procedures or protocols that if we do these things, it mitigates or eliminates the Ebola.
That's correct, Halloran. And now you've heard about survivors and them donating blood or plasma to patients that have active Ebola. And that's trying to give them some products that their immune system has created that could help them fight the virus. It's not for sure that that's beneficial, but it may be. And it's as long as the patient that's donating doesn't have any other disease that in their blood that poses a new risk to the patient that's sick, it's certainly something that makes sense to try.
All right, thank you. Dr. Buchanan, if someone here in East Tennessee is determined to be infected, will the patient be treated here, or do they move them to Atlanta or Bethesda, as is what happened with the two nurses from Dallas?
That's a great question, and honestly, we don't know the answer to that question. We may know before if we have a case, we may know before that. That's still being discussed at a very high level with the CDC and others and those institutions, whether that's even reasonable to do. So that's one of those questions we don't know yet. We may find out in a few days. We may not find out until we possibly have a case here.
All right. 6:20 is when we will start taking questions from the audience. So if you want to get those in, make sure you get those in now. So remember, we need those in by 6:20. Dr. Buchanan, back to you. What's a good solution for treating or disinfecting surfaces to protect against the spread of Ebola? And I think we mentioned something about Clorox bleach and 9-to-1, but would you talk a little bit about that? And would you talk about over-the-road truck drivers, what they might do to keep their cabs clean, and people who are moving about the country?
Sure. So as has been stated, good old-fashioned household bleach is a great disinfectant. It neutralizes lots of things, including Ebola and norovirus, the cruise ship virus that you hear about. So that's in a 1 to 10 dilution, or 1 part to 9 parts. And any household cleaner, any EPA-approved cleaner that is effective against norovirus, which is actually harder to kill than Ebola is, will take care of Ebola. So if you look at your whatever it is you have at home to clean, that you disinfect your bathroom with, or at the hospital what they disinfect with, it'll tell you what it should be effective against, and those things. Or if you want to go to the CDC and or the EPA, you can download a whole list of products that are effective against norovirus, and all of those will also be effective against Ebola virus. So over-the-road truckers, for people who are traveling, like I said previously, travel in the United States is not a risk for Ebola, so they don't need to worry about protecting themselves against Ebola, but there are a lot of other things they need to protect themselves against, like influenza, the season has started, other viruses, other illnesses that they could get. So good old-fashioned hand washing and keeping your truck tidy and cleaning up and wiping it down as you need to is really the way to protect your health when you're traveling.
Let's talk about people who've traveled overseas. Are they at risk? When you travel, should you wear should you wear masks? Should you do that? And the question here says, should I avoid traveling until the outbreak stops?
Absolutely not. I actually am flying to Canada next week and don't plan on using any protective gear, and am not concerned at all about becoming ill. And we even talked about, would any of us be concerned if we found out we were on a plane with somebody who had Ebola? And none of us really were. If we're not having that direct contact with that person, it's not something that just floats around in the air and makes other people sick. So traveling in itself is not dangerous. It's that direct contact, and you really don't have that kind of contact on a plane with other people that would be required to make you have Ebola, unless, of course, the person next to you is really, really sick and unfortunately they throw up on you or something like that. Obviously, that's a different situation, but in general, travel is safe. There's no need to do anything more than wash your hands and get your flu shot.
All right. I think Dr. Buchanan and Dr. McBride will want to weigh in on this next question. It says here, should I avoid going to the doctor's office or hospital until it's proven that there are no more cases of Ebola in the United States?
And again, absolutely not. We don't want people not going to the hospital if they need to, if they have a heart attack. Again, we don't have any cases of Ebola outside the 2 institutions that have those 2 nurses right now in the United States. And even within those institutions where those nurses are being cared for, are very, very isolated, very, very specialized units. So we want you to get your regular checkups, go to the doctor and take care of your diabetes, and go to the hospital if you're going to have a baby or have a heart attack or anything else like that. So we want you to seek medical care when you need to and keep up with your regular checkups. And we're going.
All right, thank you. We have been very time efficient, so we've gotten through the formal questions here. Would you join me in thanking our panel for answering those initial questions? So we're a bit early. It's now time for our audience Q&A. We will address some of the questions that have been submitted by our audience, also a few that were submitted by mail. Let's have a few of our audience members step up to ask their questions of the panel, and I think our event coordinators will help us with that. I think we have microphones in the audience, so we can start taking these audience questions. Yes. Yes, we have...
Thank you. Just while we're waiting for folks to get down here, Dr. Brooksbanks just reminded me, an important thing to note, hand sanitizers are soap, and soap are for your hands and your skin. Bleach is not, and 100% bleach is really, really not healthy. It can be really damaging to your skin. It's not made to wash your hands in. Good old-fashioned soap or hand sanitizers work just fine. So use the things that are made for skin on skin, and use the things that are made for hard surfaces on hard surfaces.
Thank you so much. We have some great questions submitted from our audience that haven't been covered already, and I'd like to invite a few people to come down to ask their questions of the panel if they would like to do so. Roger W., Cliff T., Michelle C., and Maggie A. We'd love to have you come down and ask your questions directly. As you head down this way, we also had some questions that were submitted via email in advance that we found to be important questions. Let me kick off with a question I think will be handled by Dr. Sousa. This comes from John M. He said, I work in the pet industry, and I've heard people talk about pets contracting Ebola. Can I give my pets Ebola and vice versa? If so, how can I tell that my pet has Ebola? And what will happen to my pets if I contract Ebola?
So right now, there's no evidence that domestic animals, typically dogs and cats is what we think about most commonly, but also livestock can actually come down with symptoms or signs, as we say in the veterinary world, of Ebola virus. And so there's really no fear that those animals are going to actually get sick from it. There is some evidence that certainly these animals can be exposed to it and develop an immune response to it, but there's no evidence that they're actually involved in the transmission to people or other animals. The question about whether a person is diagnosed with it, what's going to happen to that pet dog or possibly pet cat, and this goes back to the case in Dallas, and certainly the recommendations from the World Health Organization as well as our CDC are that those animals are placed in quarantine for 21 days, much like we do people. And that's something that we would probably pursue here in Tennessee if we were to have a case as well.
Actually, I was curious as to what would be the safest way to take care of a deceased person with Ebola? I mean, I haven't heard anything on the news. Do they burn the bodies? Do they bury them? How does that work?
Yeah, sure. So the safest way to care for the deceased body is also the safest way to care for the living person who has the disease, using personal protective equipment that we've talked about, gowns, gloves, masks, and all those things to process the body. And our local funeral home directors and folks who were also involved in our H1N1 and pandemic planning have those things in place when they have to deal with bodies that have other illnesses. As far as burial versus burning, it doesn't matter. Our burial is so, there are lots of steps to it. And so once the body's cleaned and if the body is burned, it would not put off the virus to make anybody else sick. So either way.
Okay, great. Thank you.
Thank you for your question. Next.
Since testing for Ebola is potentially an alarming thing to have a result from, do any of you see that is there any likelihood for a need for pre- and post-testing counseling the way it's done for other kinds of alarming and frightening tests? In other words, should our readiness planning include that kind of counseling in addition to the usual very good access people have to mental health and pastoral care in our community?
That's an excellent question. For a suspect case to show up, that's going to be a very dynamic, fast-moving situation. And there will be physicians that will have contact with that individual in terms of bringing in extra people or counseling or even chaplains. We've considered what would happen if someone was very distressed and wanted their chaplains to talk with them. And so we're looking at ways to have people communicate with that patient without having physical contact, be it by telephone, by video teleconferencing. We have iPads with, video chat that you can set up in minutes. We went through issues like this in the world of HIV a while back, where pre- and post-test counseling was really critical because we didn't have anything to offer those patients vis-a-vis treatment. And that would be a consideration. I think that's going to fall on the shoulders of the physician that's in the room. And that's just part of what we would do if we get bad news all the time, unfortunately, about diagnoses of cancer or about diagnoses of other diseases that may be difficult to treat. And we would just have to approach that with the same compassion that we would bring forward for other things that we deal with that can be pretty devastating for the people that we give the information to.
Thank you very much. Next.
Yeah, Yes, being in the construction business, I had a question about, interested to know what types of materials should be or not be used, wood doors. We're talking about lock sets, carpet, paint, or wall coverings, those things that are in the room. With this Ebola, may not even be as much of a problem as it would be in some of the airborne type problems. So the other question was, or part of that was, there are a lot of products that are antimicrobial products. Are those being thought of, and are those being brought into the different rooms and areas where Ebola and other infectious diseases are?
All right, thank you for your question. Any of you panelists want to tackle that?
Not exactly a construction expert, but I have known as Daddy Fix-It. As far as materials are concerned, if something were to get severely saturated with infectious fluids, be it blood, urine, stool, whatever, it would have to be able to be subjected to appropriate disinfection. And I guess if something were to be so heavily contaminated that it just simply couldn't be disinfected by routine means, then it would have to be disinfected by some sort of destructive means, incineration probably. Insofar as most of our surfaces, things like lock sets and things like that, those are going to be metallic and easily disinfected by the common normal disinfectants that we use. Painted surfaces are probably not going to be very permeable to the infectious fluids if they were to contact them, and could probably be disinfected with reasonable disinfectant agents. Even carpeting to a certain extent might be. But that's something that can be taken up and replaced a lot more easily than structural materials could be. So far as the antimicrobial compounds which surround us now, it's in just about every laundry soap, hand soap, bathing soap, everything wants to advertise it's got antimicrobial in it. The agents that are used in those products are rather weak disinfectants, and by and large are probably not going to be reliable inhibitors of something like Ebola. It is easier to kill, as Dr. Buchanan said, than norovirus, which is something that's commonly encountered, the cruise ship virus. But for my money, I would go back to good old-fashioned stuff that works real well and is cheap and readily available, and not worry about trying to rely on the latest and greatest soap that advertises that it's antimicrobial. Soap itself, intrinsically, is pretty darned antimicrobial without anything being added to it.
I think of the products, there are wood doors that have an antimicrobial, what's the word?
Antimicrobial.
Microbial, I'm sorry.
Well, you can add a 20% increase just for putting that word on the package, I think.
Yeah, I think so.
Let me add a couple things too. If you really go to your hospitals, we think a lot about what the hospitals, emergency departments look like. If you walk through a lobby there, we're used to taking care of patients with different kind of viruses all the time. Mm-hmm. The chairs can be wiped clean with disinfectants. Sure. The rooms have hard surfaces in it. They really don't have carpets in it for that very reason. Mm-hmm. So we're very well prepared for cleaning surfaces for a multitude of viruses that have been exposed to. Janice, do you want to make any other comment about that?
No, I agree with that. We look all the time at what we provide in our surfaces. I don't think you would need to add anything for this particular outbreak.
Good. Very good.
I have a question for you guys. So it seems like the best defense against Ebola is a robust immune system. When you become so clean, can you break down the body's ability to fight disease because you've used too much of this antimicrobial microbial stuff? Because you're too clean, so your body's immune system doesn't stay in fighting shape? One. Two, are there things you can do to boost your immune system just as a matter of regular health hygiene?
If you could boost your immune system, you probably wouldn't want to. It would probably cause heart disease and strokes and other things from an overzealous immune system. In terms of the widespread application of disinfectants on society, hand soaps and everything that's routine, that's probably not a great idea unless you're working in a hospital environment or you're a school teacher or you're likely to encounter infectious body fluids as part of your day-to-day activities. We have more bacteria on or in our body than we do human cells. And there's a delicate balance between non-pathogenic bacteria and, as you alluded to earlier, the good bacteria that sort of protect us from other things and form a nice barrier. And so just wantonly destroying these things is not necessarily a good idea. You don't want to be filthy either. In the hospital, I wash my hands dozens of times a day or treat them with alcohol gel because it's an occupational hazard for me and my patients if I don't. For the average person going about their day-to-day lives in an office building, it's probably overkill.
All right, thank you.
Just one more point about boosting your immune system. Doesn't really boost your immune system, but keeping your immune system healthy is all about a healthy lifestyle. Eating well, regular exercise, good sleep are all key to keeping your immune system healthy, and so that'll keep your immune system healthy and active against anything that might come your way.
Thank you. Ward?
This is another question that was emailed to us, and I think maybe something Mr. Hamby would like to comment on. This comes from Trudy in Loudoun County. She said, I understand the concern for protective measures for all personnel in the emergency room and in hospital emergency departments. My question is, what is being done to protect our first responders? Paramedics, EMTs, and fire department personnel will be coming into contact with infected people and their families prior to going to the emergency department, perhaps.
We have been very active with the Tennessee Department of Health Office of Emergency Medical Services to share information with all the ambulance services, the emergency medical services, and seeing that they're handing that information on down to the first responders. We even had some difficulty getting it down to the first responders, but I think we've worked that out, and we're constantly sharing that information with them so that they're aware of the changes, such as the new PPE requirement that the CDC is actually coming up with. So we're sharing that information every day, day in, day out, making sure that the first responders are aware of what is required of them. And it's a real good time to allow the services and the medical directors to review their infectious control plans, making sure that they are prepared if they do have to respond to an instance such as this.
Take that as well. First of all, that's a great question from Trudy. Our EMS providers are a key to our chain of taking care of patients every single day. As we look through patients, when they call the 911 center, we're building processes in place for protocols to screen those patients, meaning that we ask those questions. Have you recently traveled to West Africa? Have you been to these 3 countries? Have you had a fever? So we're screening the process on the phone call when someone calls and requests EMS. That information is given back to the crew so the crew is well prepared when they come on scene to be protected, to be able to take care of patients, and to be adequately screened and take those patients to the appropriate locations.
Thank you. And we received another question from Kevin in the audience, if he would like to come down, that I don't think we've covered yet. While we're waiting on Kevin, another question that was emailed to us, this is from Lynn in Oak Ridge and might be something for Dr. Watkins to talk to us about. She said, over the years, my husband has been a frequent blood and platelet donor. Given the recent use of transfusions as a first-line treatment for Ebola patients, I have concerns about the safety of workers who will handle these blood supplies, as well as for the donors and recipients of blood and blood products.
Well, that sounds like a bit of a multi-headed question here, so I'll try to break that apart a little bit. I think first and foremost in a lot of people's mind would be the worry of what I would call a transfusion-transmitted Ebola. And in that regard, I think the blood supply is extremely safe. Now, there is no screening test for blood Ebola, but in lieu of that, we have a number of questions we ask blood donors, one being where they've traveled, and in those, it was initially put in to prevent someone from having traveler-acquired malaria from donating blood. And the areas where malaria is endemic are, at this time, the areas where Ebola is also occurring. So those people who've been to Africa on a mission trip or something would be excluded as blood donors. So that pool is out. Another worry then would be a sick contact here in the United States. So like the Dallas, the nurses, or the family of the gentleman that passed away. His family then that was under quarantine, or people that were contacted with the quarantine, we have a group, America's Blood Centers, and we've agreed that for 28 days, if you've been contacted by a public health official that you were in this quarantine group, or you've contacted one of these patients, to self-defer donating blood for 28 days. And again, that's only these people who are contacted by that group. So as far as a blood donor possibly having Ebola donating into the blood supply, I think the odds of that are astronomically low. The other question, I think the other head of the question, if I'm understanding it correctly, that you asked, might be what hazards would there be for the blood center maybe obtaining blood? We talked about the transfusion support, or obtaining a plasma unit from an Ebola convalescent donor, or Ebola convalescent person to give to someone. There was a circular that floated again around my organization, inside of America's Blood Centers, and it described the experience at one center where they brought in I think it was the doctor that had recovered from Ebola, and obtained a unit of plasma from him to give to another patient that was recovering from Ebola. And again, I don't think there would be any risk. He has already recovered. He's no longer infectious. Obtaining a unit of plasma is something we do pretty readily and are very, very well equipped to do. But there was a series of steps that particular communication laid out as to how the request came in, how the request was handled, and we do have a mechanism for directed donations of blood. So we definitely have tools in place to take that request, obtain a unit of plasma, and send it the right way. And certainly it sounded through the communication that I'd read that the CDC had helped shepherd quite a bit of that movement. So I think that's the second head of that question. I hope I'm not missing a third head.
Thank you.
Okay, yes, in the case of Mr. Duncan, there was extreme vomiting, and it's my understanding that in 40 to 50% of the cases, the Ebola, the bleeding occurs into the mucous membranes, which would be in sneezes, droplet aerosols, that type of thing. So I'm wondering, what protocols do the hospitals have for contamination control line protection, like UVC? Is that in any of our protocols to make sure droplet, as far as air transmission pathways, is eliminated?
I can speak for us, and I think every hospital in the region would have these facilities, not necessarily UV, which is a tool that would be effective, but that's not widely deployed at all hospitals. But the airborne isolation rooms, we all have identified to place a suspected Ebola patient in. These rooms turn over the air supply multiple times an hour, and they process it through HEPA filters that would remove any potential infectious particle. And again, that difference that you alluded to earlier between an aerosolization event, like a violent episode of vomiting, that can create a brief aerosol, that would pretty rapidly be cleared by the air handling in that room, render it non-infectious. Staff that would enter that room would be wearing respirators, either the fitted N95 masks, they're called, or the full hood PAPRs, the powered air purifying respirators that you see that look like the big hooded suits. Those would reliably scrub out any infectious aerosol from going into your lungs if you walked into that room. But the very nature of managing TB effectively in the United States, that's a thing that hangs around for hours to days in a room as an airborne product. But the rooms that we have pretty rapidly will scour TB from that room if someone coughs it into the air. And we would suspect if we had an Ebola patient, it would do the same thing.
Once again, though, to emphasize that the droplets that would be generated by vomiting, sneezing, coughing, the like, disperse straight down to the floor or other horizontal surface within a very short distance of generation. So the kind of particles that are of sufficient size that they will waft for long distances, which can convey organisms such as tuberculosis, and are the reason why we have the very stringent precautions that we do utilize for TB. Those kinds of particles do not convey Ebola. The larger particles that could contain Ebola will fall out within 1 to 2 meters of source.
I have another question. The people that clean up hospitals, are they being briefed and prepared? The people who do the cleaning and who dispose of things at hospitals, are they being briefed and prepared?
Absolutely. I think every hospital has begun that process. They're very much part of our team. We will be looking at certain ones to train very intensely so they know exactly what to do and how to use the solutions that we've alluded to. But I know, Dr. Childs, we talked a little bit about that yesterday.
Okay, thank you.
I think to be highly reliable at caring for these patients, and as they get sicker, you really have to be perfect. The housekeeping staff is going to actually teach physicians and nurses through glass, make sure they're actually doing the wiping up and cleaning predominantly, so that the entries to these the rooms are minimized. I think they'll probably will enjoy that to some degree if that happens. I hope it doesn't. But then focusing on how then the gowns that are removed and any medical waste is handled is certainly paramount in making sure that this all is safe for the community.
Another submitted question from Amanda in Knoxville that might be appropriate for some of our panelists from the Tennessee Health Department. How is information about Ebola being distributed to the very rural areas in East Tennessee?
Well, we're having daily conference calls with everybody, and then we've also brought staff in for several trainings, and we've done actually tabletop exercises in all of our rural county health departments. And we're getting ready to do a specific training on donning and doffing PPE.
Another submitted question for Dr. O'Brien. Is there added focus and discussion among your members at the Knoxville Academy of Medicine to share information and best practices for preparation?
We are actually planning right now some events for our members and for their staffs to do that. That'll be probably within the next 10 days. Those discussions are ongoing. Our staff keeps up with what is going on with the Ebola and other things. I mean, every day we have many members in this community. We have hundreds and hundreds of physicians and their staffs who are attuned to this. And we, as their organization, their medical society, are working with them to prepare them to take care of Ebola and other diseases. So specific to this, we'll be doing some training here within the next 10 days.
I also have another question from the audience. If Leonard V. is still here and would like to come down and ask his question, a question from Leonard. In the meantime, we had a submission from Michelle for Gail. Gail, what is the best advice for responding to media inquiries about how my organization is handling Ebola?
When we get an inquiry at the regional health office, I will talk with our Nashville office, also talk with our communicable environmental disease program, and involve our health officer, Dr. Tara Sturdivant. Most of our communication and press releases are coming out of the Nashville office. They're handling all of that.
I've got a question for Dr. Buchanan. It's a two-part question. Number one, we see CDC involved, and I think they're the group that brings in the PPE, what I call the marshmallow men. Okay, it's possible there's other organizations, but what role does Knox County Health Department play when CDC comes in and starts interacting with an event. That's question one. Question two, I was surprised in the media one day when I heard that a bus had been disinfected because a child that bus rode on, that person was in the plane that was part of the Frontier flight. And so I think it created quite a bit of unnecessary overreacting of disinfecting everything everywhere, all over the country. It ostracized the child because now his friends are warned, you might have touched the child who then was with the plane of the person who was flying on Frontier, and it got all out of whack. So I would like to just, as question two, an airplane comes into Knoxville. We just received a person that had Ebola, maybe fever, and there was a child on the airplane. What happens next?
Okay, so to your first question, having never been in a situation where the CDC comes in and kind of takes things over, in my time at the health department, what I believe would happen is we would play a supportive role, being the liaison between our local partners and the local media to facilitate the CDC and kind of be their legs on the ground for some of the things that happen here and helping them navigate the local system, because we know our partners, we know the media, and they certainly don't have that knowledge. So that's the role I see for us, and continue to communicate with our partners and with our community. So to your second question, and so if there is I got to remember the sequence. So a plane with a person who we know has Ebola, not just a person who isn't sick with Ebola. So the person's sick with Ebola?
No stool and no
symptoms?
Whatever the other was. And
no fever?
No bodily fluids.
None of that stuff.
Similar to Frontier.
So I agree that there's been a lot of overzealous cleaning going on across the country in various places, and that things have happened in an abundance of caution and contributed to the fear that people have of Ebola. If a person with the disease who's actively ill is on an airplane, where they sat and surfaces they touched do need to be cleaned thoroughly, absolutely. And the people that were immediately next to them need to be followed and for 21 days to see if they get sick. But the kid on the bus, I think I was a little overzealous on their part, but a lot of that is just not being very familiar with what would happen, with what to do. So if that same kid were here, my advice would not to be to take the kid off the bus and scrub the bus and all of those things. But that kid he poses no risk. If he's just on the plane with somebody who had Ebola or was incubating Ebola, he poses no risk unless he himself becomes ill and exhibits symptoms of Ebola, and then he could make other people sick. And that's been my message when I've gotten calls and questions about things like that.
Thank you.
Another email question in general. How long does the CDC expect that it will take to control the outbreak in Africa? And will that continue to present a risk to U.S. citizens, specifically to East Tennessee?
The latest projections that I've seen online for Africa are not very optimistic, and no one is really talking about controlling it. They're talking about just trying to get assets in place to start controlling it. Incredibly austere environment, incredibly limited medical assets, very few people now that are signing up for these aid agencies. We've had in the news in the past months doctors in East Tennessee that had traveled in the early phase of this epidemic as part of aid organizations to try to help. So their pool is drying up. There's a major military effort underway to try to get logistics and infrastructure and build hospitals and treatment beds. The one that they opened up last week filled the first day they opened it. And so there's some pretty pessimistic considerations out there from WHO and CDC about no one's really putting a timeline for controlling it. So action definitely to protect us here needs to be on the ground in Africa to try to get the outbreak under control. That's just complete speculation on anybody's part as to how that's going to be accomplished, but it's going to take people on the ground, it's going to take money, it's going to take infrastructure, and it's going to take time. And so I think it's going to be a period of months that hospitals in the U.S. need to be prepared. and I think we need to watch things daily. The list of countries that are involved are probably going to grow. The number of cases over there are probably going to grow. And so we'll need to constantly revise our plans for which countries we ask about as things go forward. By saying that, it's not hopeless, because Nigeria, who does not have a tremendous amount of infrastructure and resources, with that heroic kind of assistance from the CDC, who sent boots on the ground to Nigeria and really got that flare-up under control. I think it was 20 cases and 8 deaths. You had alluded to that before. They pretty rapidly got that under control with vigorous contact tracing. It's just gotten so big in those 3 countries right now. It's unprecedented, and so the World Health authorities are still struggling.
Another question for our representatives from the health department. Would you say that Tennessee is prepared, and what has Tennessee done to uniquely be prepared for the threat of Ebola?
Checking with my colleagues down there. I would say that Tennessee is prepared, and what have we done uniquely? I think here in Knox County, I can speak for Knox County specifically. What's unique about Knox County is you see a bunch of competitors up here talking with our community and putting down that competition and saying, we're going to work together, we're going to do things in a similar fashion, we're going to, we heard the word triage tonight, that's asking people questions, and that's unique. We recently, in the past, during this week, my staff has been working with our outpatient providers, Summit Medical and the others that have outpatient facilities, to say, okay, let's all screen everybody the same way. Let's ask the same questions. Let's agree on what we're going to do, so that when you go to a doctor's office in East Tennessee, or at least in Knox County, you're going to be asked very similar questions, and we're coming from the same page. And I think that's unique, because medicine, there is some competition there, but they're willing, for the good of the people here in the community, to say, we're not going to worry about that. We're going to do things the same way, so that people understand what's going to happen, and so that same things happen. And we're updating that regularly, so that if the country list changes, the country list changes on our guidance too. So I think that's how we've uniquely prepared for Ebola.
And when we talk about emergency preparedness, and from the East Tennessee Regional Office perspective, certain triggers can occur that will cause us to review our emergency operations plans. That could be something from out of an improvement plan, from an after-action report after an exercise. That could be a change in our hazard vulnerability analysis that we conduct on an annual basis. It could be just things that are happening. In our case, all those triggers have occurred, and we have taken a good look at our plans. Our emergency operations plan consists of a basic plan with 25 annexes, and then various supporting appendices to those annexes. And one of those is our infectious disease response plan. And we conduct I would say, pretty robust exercise program, or we impose that upon ourselves. And in recent weeks, we have conducted a regional tabletop exercise. We brought all of our county health department directors, and we have 15 county health departments in the region, by the way. And we brought in the nursing supervisors from those health departments, and we provided not only training on Ebola, also exercising on how we would respond to it, but also training on personal protective equipment, donning and doffing, and those type of things. And from that, we realized very quickly we probably needed to do that out in each one of our 15 county health departments also, so we've also done that. And they have exercised on, should a person walk into one of our county health departments, they're probably not coming there to seek treatment, because that's not what we do, but they could still present. So we want to get them isolated and get them to the to the hospital and wherever we need to be. So there has been a lot of work going on lately as far as in the region within the health departments for that.
Thank you very much. I think this is great, the city, like you guys coming over here, talk about taking time out, spend about the knowledge about this unknown disease. You know, when we had entertaining HIV years ago, it's almost under control. Now, I'd like to tell you the story this morning. One of a lady, she's not my patient, but she called our office. My husband is passing through Dallas, Texas today, and stopped by, had a hamburger French fry call. So what do I do? You know, I think immediately my staff, they were laughing, but I don't think that was funny at all. This is seriously. So I'm so happy that you guys squeeze out your knowledge to our beautiful community here. This is a big deal. I think I told that lady I'm going to the forum here tonight, and I'll tell you tomorrow. So I think I'm sure you guys have the same problem. Every day they call about this. We gotta really hit the bottom. Don't scare them. You know, Dr. Adams said, don't scare them. But when you have HIV coming down here, we were so scared. But I don't think we shouldn't be really intimidated this. So I'd like to share this story with you.
Howard, if I could follow up on that, I would, as a recipient of some of the collaboration from folks at the table, I can tell you that this community is very collaborative. The communication across, we've been referred to as competitors. I don't really think of myself as necessarily a competitor in the marketplace. Most of us went into medicine to serve, to help others. And I think this is evidence of that. You know, we have a potential threat, one that's very scary, one that induces a lot of hysteria. And hysteria is not limited to the media. It's not limited to the public. It also occurs inside medical groups, inside hospitals, inside staff. And so effective communication across the continuum is key. Martha Buchanan and the folks at the health department had developed some wonderful workflows for outpatient practices who are potential points of entry for folks at risk, potentially, of the disease. And I think those are going to be disseminated across the community if they've not already been done so very soon. So just this morning I sat down and briefed our 50-some-odd site managers and managing partners who participated in a call across our organization just to make them aware of the progression and the things that are coming to light as we evolve our response appropriately to the threat and help educate folks. But I think there's a very good communication and collaboration across the healthcare community here. I don't know that's necessarily unique, as it's been said. I think that healthcare providers at large, whether we're talking about physicians, nurses, advanced practitioners, or support staff, we're here to help and serve the community.
Well, that's, we've covered a lot of ground and we've been very time efficient. I hope you will take note of the fact of the way this community, without a crisis actually ongoing right now, decided to come together and collaborate ahead of time. And so to see, you know, this assemblage of great medical professionals all dedicated to keeping our community safe, that's really impressive, and I hope you will join me in giving them a round of applause for being so willing to do that. So thank you for coming out this evening. There is a website if you want further updates. If you want to access video footage, you can go to ET Health Forum, ethealthforum.com. We hope this has been informative. It has helped you out. We'll also be calling on this panel to help us this weekend against Alabama. Thank you very much. Have a great weekend.